From Loyalty to Advocacy, a New Metaphor for Nursing, Gerald Winslow. In his article, Gerald Winslow looks at what he takes to be the two prominent models of ideal nursing practice. That is, he's essentially looking, as we did with the physicians, at what is the appropriate relationship between nurses and their patients. In doing so, he examines the sort of historical model of nursing, the military metaphor, and contrasts it with the more contemporary version of nursing, that is the legal metaphor, what I call here the advocacy model of nursing. So what Winslow is going to do is first show where nurses started out, that is with this military metaphor, that nurses are to be essentially military personnel that follow orders, that is the orders of the doctors, and see how that has slowly changed into this new legal metaphor, or as I've termed the advocacy model, where nurses are to do more than simply follow orders and in fact have special responsibilities to the patients that they're taking care of. The military metaphor. The military metaphor of nursing dates back to the 1850s and the Crimean War. Essentially, this was a time when Great Britain was fighting with Russia in Southeast Europe. A nurse there, Florence Nightingale, has been attributed with the beginning of modern nursing, where she imposed upon her nurses a strict sort of military discipline. In this type of discipline, the nurse was to follow the orders of the physician and to understand that their job was going to be a difficult one with long hours and would be physically and mentally demanding. Now, the military metaphor advocated by Nightingale still exists to this day. Many times, doctors in particular view nurses often as their assistants in this way, as sort of their cohorts in the fight against disease. And so the military metaphor, although falling out of favor, and in many places has already fallen out of favor, still has generally this idea to it that nursing is a difficult profession in which nurses are assisting physicians, much like soldiers assist the general or whoever happens to be in charge. Military aspects of nursing. As was mentioned, the military model requires that nurses have a large degree of discipline in what they're doing. In addition to discipline, there's an acceptance of the hardships of service. So under the Florence Nightingale model, it's assumed that once you become a nurse, you should understand that much will be demanded of you. And probably the most important aspect of this model is the respect for those of higher rank. So we have the ideal of military obedience to physicians. What the physician says is not to be questioned, and the orders are to be followed regardless of what the nurse believes to be the best course of action. Loyalty to the physician, just like there would be loyalty to commanding officers. In other words, nurses would not question the orders of their doctors, nor would they speak ill of the commands given them by nurses of higher rank or physicians. And nurse, essentially on this model, is the handmaiden of the physician. So the nurse is simply to do what the doctor orders. Now, obviously, there are cases where a nurse may see a doctor who is given an inappropriate order, maybe misdiagnosed a condition or wrote down the wrong prescription. Depending on how this model was viewed, and we'll get to some of the legal cases involved with this, the nurse was not actually supposed to directly confront the physician in these cases. But this, of course, presents a problem because the nurses, although they have no formal responsibility to the patient, because at this time, under this metaphor, the nurse's sole responsibility was to those of higher rank, to the doctors and to other nurses. So the moral conflict here actually came between the nurse's personal morality and the sort of professional requirements that they had. And so this posed a problem for the nurse, who recognized that there might be something wrong with the course of treatment that a physician had recommended. Conflicting duties, loyalty, and the military metaphor. As I mentioned previously, there were times when the military metaphor and what nurses were expected to do under this military metaphor of nursing would come in conflict with what they believed their general moral duties were. Winslow points out 3 instances in which there might be a conflict between what the nurse may consider her moral duty and what the military metaphor required. The first case is that of the incompetent physician. The question is, what should the nurse do? Should they tell or not tell on a physician who they believe to be incompetent? Under the military metaphor, it's difficult to see what the correct action is, because under these situations, the nurse might say to herself, well, my obligation is to follow the rules of the physician, follow the directions of the physician without question. And so in such cases where, even though I know the physician is incompetent, it seems that the military metaphor tells me that I ought to still follow those directions. A second case is the deceptive physician. So a physician who keeps a patient's condition from them or a treatment option from them. The question is, what is the nurse's duty to the patient under the military metaphor if the patient were to ask them directly for information? So let's say the nurse knows that there are multiple treatment options for a particular disease. Or maybe the nurse knows that the patient is much worse off than the doctor is letting on, and the patient says, is this true? Or I suspect the doctor's keeping something from me. Is this the true nature of my condition? Under the military metaphor, it seems the requirement is to follow the orders of the physician. If the physician has stated that this is what they're going to tell the patient, then the nurse is not expected to violate that confidence or that rule of the physician. The third case, and this is one that we see less these days than we would back when Florence Nightingale was practicing nursing, is the idea of a private duty nurse. Private duty nurses were nurses employed in private homes to take care of people. Now, normally what would happen is a new nurse would work in a hospital for a time, and then as these private assignments would open up, doctors would recommend various nurses for these assignments. So here you can see the conflict that would arise. A doctor who perhaps a nurse thinks to be incompetent for some reason, or who's made a mistake or a judgment call that the nurse disagrees with, if the nurse informs on the physician, that may jeopardize her ability to get a job that was far better than the one she had. So in other words, private duty nurses often had a less hectic schedule. The requirements weren't as stringent as those found in the hospital because there was only one patient to take care of, and so there was a lot more free time and the pay was better. So there was a conflict between self-protection or self-preservation. If a nurse ever wanted to get into a position that made her a little better off, she would have to sort of follow these military metaphors. Loyalty examined. We've been talking here about the loyalty of the nurse under the military metaphor was to show to her profession or those in her profession. In this, I just want to briefly go over what this loyalty actually amounted to in practice. Now, according to the sort of military metaphor, loyalty meant a refusal to criticize one's nursing school. So you wouldn't hear nurses speaking poorly of the training they'd received, regardless of whether that training was good or bad. Loyalty also meant a refusal to criticize fellow nurses. So regardless of what another nurse did, you were to remain loyal to your school, remain loyal to your fellow nurses, and not criticize and not mention if they had some sort of shortcomings. Finally, there was a refusal to criticize the physician under which one works. And that essentially, we've talked about already, is that it was expected that nurses simply followed the orders that were given to them and didn't offer anything in addition to what the physician would offer to a patient as far as information or treatment or anything along those lines. Dealing with the problems of the military metaphor. As mentioned previously, a nurse would often come in conflict, or a nurse's morals would often come in conflict with their duties as a nurse. And so the question is, what would a nurse do under the military metaphor when this conflict arose? Well, the first thing the nurse could obviously do is simply faithfully obey the order of the physician. Now, in that case, obviously, they're sort of abrogating their responsibility, their moral responsibility, especially in cases where the physician's orders may actually harm a patient. The second thing a nurse could do under the military metaphor would be simply to gently question the doctor's orders. So rather than deal in a direct confrontation or go above the doctor's head to someone else, the nurse could simply ask for a clarification, say, of the medication that was ordered or the instructions that were supposed to be given to the patient, and then hopefully if the doctor would realize that they'd made some sort of mistake and correct it before the nurse would administer the drugs or do whatever had been told of her to do. The next thing they could do would be to consult another authority. Now, in some cases, there would be a nurse supervisor. like a head nurse that other nurses could go to in order to lodge a complaint or a concern about a physician or another nurse. And so this would be allowed, assuming, of course, that the nurse supervisor would actually take that concern to the physician or someone else. So again, nurse supervisors might be in a similar situation as the nurses on the floor anyway. So it wasn't always certain that simply reporting something to your supervisor would actually result in any action being taken on the part of the supervisor. But that was an option for nurses under the military metaphor. The final thing a nurse could do, of course, was to withdraw from the case. And in such a situation, the nurse could simply refuse to help that patient or go on to a different patient. Again, this would put the nurse's job in jeopardy, because if a nurse would withdraw from the case or refuse to help, that might reflect poorly on her. And as we talked about with those problems with the private duty nurses and actually moving up in the field, this could cause problems. But it was an option for the nurse, one that I don't believe was taken all that often. The legal metaphor or advocacy model of nursing. It's not exactly clear when the military model sort of lost favor. We can probably trace its formal sort of abolition to somewhere in the 1970s, when the Nursing Code of Ethics and the American Nurses Association put forth the notion of advocacy as a primary concern of nurses. But earlier than 1970, there were hints that nursing was no longer going to be following this militaristic model. We'll talk a little bit about some of these cases, and these were court cases that actually changed the nature of nursing. But first, let's talk a little bit about what this legal metaphor or the advocacy model actually entails. Unlike the military model, the nurse is to act as the protector of patients' rights. So in this account, nurses are actually a go-between between the physician and hospital and the patient. The right to adequate information about their condition. Nurses are now responsible under this advocacy model to make sure that patients are getting all the information about their case. So unlike a paternalistic model of the physician-patient relationship or previous nursing models where nurses simply went along with whatever the physician decided, the advocacy model holds the nurse responsible for making sure that the patient is getting all the information. Right to information about treatment options. Again, should a physician or anyone else deny a patient information about various options, it's actually the nurse's responsibility under this model to make sure the patient gets that information. And it's also the case that the nurse must inform the patient about their right to accept or refuse treatment. So in the past, treatment was something that the doctor had ordered, and the patient was simply supposed to accept. So again, you can see that the military model also went along with the sort of outdated paternalistic model of the physician-patient relationship. Physician gives patient the information they think is most beneficial to the patient. The nurse follows the orders and reinforces those orders with the patient. Under the new model, this advocacy model, we have the idea that the nurse isn't simply to follow the orders and to inform the patient of their right not only to accept treatment but to refuse treatment, to have all the information about their condition, information about treatment options, and thus the nurse takes on something like a legal advocate for the patient. Arguments for the nurse as advocate. Winslow notes that there are several good reasons for holding nurses as advocates for patients. To begin with, nurses have the most contact with patients. So if you look at a hospital in a normal day, it's usually the nurse on duty who will see the patient several times during a single shift. The nurse is most likely to know whether the patient has been experiencing pain, what their symptoms have been throughout the day, how much their temperature has fluctuated, or any of those other things that might be important for a patient's treatment. So who's in the best position to judge how well a patient is doing may not necessarily be the physician, given the amount of contact time the nurse has with patients. It's also the case that nurses tend to be concerned with the whole patient. Nurses are going to be the ones that will most likely encounter family members or be aware of situations in which a patient hasn't had visitors. And so the nurses will look to making sure the patient is comfortable in a variety of ways. Not only is the treatment working effectively, are they getting enough contact with the physician, but other things like their general comfort and whether they've had visitors and whether the food's been good, were there any other sorts of needs that they might have. Nurses also have traditionally educated patients. So in many instances, a doctor may come in, consult with the patient, and say, I'm going to leave instructions with the nurse. And so nurses, in fact, have this traditional contact with patients and educate patients about what they ought to do both in the hospital and when they're leaving the hospital. And finally, Winslow notes, both the nurse and patients have suffered in the healthcare system. So depending on which model of the physician-patient relationship has sort of been in vogue at the time, doctors, if we're under the paternalistic sort of model, the priestly model, many times patients didn't get the best care because they weren't an active participant in the treatment. And so both nurses and patients can sort of sympathize with each other in this regard, which means nurses may be more sympathetic to the patient's needs while in the hospital. The advocacy model and the nursing code of ethics. As was mentioned previously, the change in a nurse's role from simply the handmaiden of the physician to an advocate for patients' rights was something that's really sort of come about in the last 30 years or so in nursing. Starting in around 1973, the International Council of Nurses, and then again later in 1976, the American Nurses Association, placed in their codes of ethics the idea that the nurse's primary responsibility shifted away from the physician to patient, that is, to become an advocate for patients' rights. And so much of the transition in nursing from simply being a servant of the physician to being something more than that, acting as a representative for the patient or a go-between between the physician and patient, is something that's relatively new, but was actually advanced by nurses themselves. Now, there's some reason for this. In part, it was self-protection on the part of nurses, as we'll talk about in the Tuma case and the Samara case, that to try to formalize this role of the nurse so that nurses not only can help patients in this way, but also protect themselves. Problems with the advocacy model. Although the advocacy model seems to be an improvement over the military model, there are several problems that Winslow points out regarding this approach to the nurse-patient relationship. First of all, there's a problem of the meaning of advocacy. This notion requires some sort of clarification because we're not exactly sure what the nurse is advocating. Obviously, a nurse believes that patients should have their rights protected, that they should be given information about their condition and their treatment options. But past this, exactly what is a nurse advocating for? Since this isn't spelled out, nor is it sort of contractually implied like we had in the contractual model of the physician-patient relationship, there's some ambiguity about what it is the nurse is actually doing. The second sort of problem with the advocacy model is that the laws have not kept up with this particular model or metaphor for nursing. In the past, there have been cases which seem to have pushed nurses in this direction. So we have the case of the Tuma case, which was a case from 1926. In that case, a nurse administered a drug that they knew was mistakenly prescribed for a patient. Now, in that case, the nurse's response or defense when the patient actually died due to the administering of the drug was that of respondeat superior. What respondeat superior states is that it's actually a Latin term that means let the master answer. In essence, what the Tuma defense was that since the nurse is simply required to follow the directions of the doctor, it doesn't matter what those directions are. It's the individual physician that's responsible for the consequences and not the nurse. Respondeat superior is also found in things like third parties that enter into contracts for someone else. So it's possible that I could hire someone to negotiate a contract with me with some other party. In that case, since they're acting on my behalf, I'm the one that has the consequences of any actions or any contracts that are made. It's also the case, for instance, if someone is driving a truck that my company owns, then under most circumstances, I'm responsible for any accidents that may be caused by that truck. So the individual driving the truck wouldn't actually be held liable, but my company would be. So in the Tuma case, what the court ruled was that the nurse couldn't hide behind this notion of letting the master answer. In another case, though, which seems to contradict this, is a Samara case. In the Samara case, a nurse actually gave information to a patient that the doctor did not want disclosed to the patient. Now, in that case, the court eventually overturned the ruling. It was actually a board that revoked the license of the nurse in the Samara case. But in that case, the courts ruled that, well, the nurse was inappropriate to fire the nurse for her actions. But even though the Supreme Court, in this case, in the Tuma case and the Samara case, even though the courts have ruled that it seems that nurses have responsibilities above and beyond just simply following doctor's orders, laws have not kept up to that effect. So nurses aren't actually protected if they go against the orders of the physician. Now, this varies, of course, state by state, as different criminal codes and different codes exist, civil codes exist across the 50 states. But all in all, the case that, or the point Winslow makes is that nurses don't have sort of ironclad guarantees that there won't be repercussions if they actually use the advocacy model. Another objection is the notion that patients' families are often unprepared to view nurses as advocates. Normally, when we go in the hospital, we don't necessarily think of nurses as our representative in any sense to the hospital. We view nurses as those who might act as a means of contacting our physician. We might ask questions about our care. We might have complaints or concerns or something that we might go to the nurse. But most people, and probably most families, still don't view nurses as advocates in this way. Now, that may or may not be changing. It's something I guess it's an empirical question we'd have to check into. But there is some question as to whether or not this model has been used widely enough to make it a common notion for people to think, if I'm having a problem, I ought to speak to my nurse. Problems with the advocacy model continued. There are a few more objections that one can make with regard to the advocacy model. Another objection is the advocacy model is frequently associated with discord. In other words, we might want to ask the question, exactly how do we want to conceive not only of the nurse-patient relationship, but of the doctor-patient and nurse relationship? So in part, the problem with the advocacy model is, does this misconstrue the nature of the doctor-nurse-patient relationship? So there are two types of models. We can view the doctor and patient as somehow antagonistic, that there's a problem with that relationship which requires the nurse to act as a go-between, as an intermediary. Or we might want to view the doctor-nurse-patient relationship as a team effort. So doctors working with nurses and the patient together are attempting to cure an illness or get someone healthy or whatever. So however we want to characterize that. But we can see that putting nurses as advocates implies in some sense that patients need protection. And so this may, as Winslow notes, misconstrue that nature of those relationships. Another concern is, are nurses properly prepared to be advocates? There is, of course, a vast amount of experience that doctors have due to their training as to how to treat patients and what information to release and when and so forth. And so the question is, do nurses have the expertise to actually act as advocates? We might ask questions about medical expertise. We might ask about legal expertise and quite possibly moral expertise. So when nurses are acting as advocates, when they're making justice claims or protecting patients' rights, the question is, are they properly prepared to do that? Have they been trained to do that? And that's sort of an open question, which may raise some concern if we're to say that nurses are to act as an advocate, yet don't have any special training to be an advocate for their patients. Another problem with the advocacy model, and this may not be with the model itself, but with the look or the way in which it appears to others, the push by nurses for adoption of the advocacy model may appear to be self-interested. In other words, it might be viewed by some as a way for nurses to make themselves seem more important than they actually are. So it's not that the advocacy model is needed or that patients' rights have been actually violated, but that nurses want to get the prestige for more authority or more money or something along those lines. And so some criticize the advocacy model as something which isn't actually necessary. We can imagine, of course, if we had a doctor-patient relationship that was essentially contractual, as was mentioned in the previous article, then the question would be, what need would there be for a nursing advocate? If doctor and patient have an agreement and understanding and which sort of rights and values ought to be supported, the question is, why are we going to need the nurse to act as a go-between? Finally, there's the idea of conflicting loyalties. Patients come and go, but doctors and nurses stay. And so the idea that a nurse is going to be loyal to a patient, and that patient will only be there for hopefully a short period of time in a hospital before they go home, does this actually sort of, again, going back to that team notion, break down the good feelings between doctors and nurses, the ability to work together? And so there might be a conflict of loyalties. The doctors are there day in and day out working with the nurses. Nurses might feel that they do, in fact, have some loyalty to these doctors. Yet the patients come in and they're supposed to somehow put that loyalty aside and take on the interests of the patient. And so there's some question as to whether we can balance, or a nurse at least, nurses can balance these conflicting loyalties.